Welcome everyone to our sexual health and intimacy presentation. We have Dr. Bober here with us today, and yeah, feel free to take it away. And we will be doing some live Q&A at the end of the session. So if you have questions, feel free to send them in the chat as we go through, and then we'll address them all in the end.
It's really a pleasure to be here. Again, I'm Dr. Sharon Bober. I'm a psychologist and I direct the sexual health program at the Dana-Farber Cancer Institute. And I really want to talk with you all today about what sexual health and intimacy looks like in the context of ovarian cancer, and more importantly, what next steps are for thinking about sexual wellness and recovery. So see if I can advance my slides. All right. Just to share quickly about disclosures and disclaimers, I appreciate that there'll be some gender-specific language in the presentation, but very much understanding that that there are certainly many different identities and genders that are often used. And really want to start us off all by sort of just appreciating that when we think about when people ask me about sexual health, I really want to clarify I really see sexual health as just being about health, right? It is really about health and well-being in total. It is not something that should be off the list or special or different. But that being said, we know that sexual health truly is like the elephant in the room for so many people when it comes to cancer. It is something that lots of people are thinking about at some point in the cancer journey or continuum of care, whether it's getting back to something or trying something different or just trying to figure out how to feel whole in your body again. Considering it is really one of the most common issues for most people after ovarian cancer that gets disrupted or changed, it is surprising how often we really don't talk enough about it. So, why is that? I really just want to, again, pause for a moment to acknowledge that even though we live in this culture that is really sort of saturated with sex in lots of ways, I would argue that we don't have a lot of real conversation about real sexuality, right? And we know that there's a lot of confusion about how to start these conversations. When we do surveys with medical providers, they say, yeah, it's important, but I'm waiting for the patient to bring it up. And patients say, yeah, it's really important, but I don't want to bring it up unless my doctor talks about it first. And it's often quite honestly, a little bit of unclarity for providers about what to say sometimes when a patient endorses a problem, because people truly don't get much training about how to talk about this or really about how to address it. So I really want to acknowledge that. And I also want to acknowledge that all of the treatments that we bring to bear when it comes to ovarian cancer has the potential to disrupt or impact sexuality and intimacy. That is something that is unfortunately a ubiquitous issue. So when I think about sexual health, I really want to underscore the point that sexual health and sexuality is really at the intersection of biology and psychology and interpersonal function and cultural influence, right? It is not only determined by any one of those things. It is really an experience we think of as what we call biopsychosocial, in that it is really at the intersection of all of those domains. We also know that, again, all of those domains can be disrupted by cancer treatment. So whether we're talking about body alterations, surgery, pain, fatigue, hormonal changes, whether we're talking about the entire experience around the psychology of how we feel about ourselves, our body image, how we think about ourselves, anxiety, depression, all of those pieces play a role. And also we know that interpersonally, relationships are complicated in the context of cancer treatment. There's often real confusion and fear of intimacy, right? About how do we restart? How do we get started? How do we date? How do we talk about this? Even if you've been with the same partner for a really long time, partners are often really unsure of how to get started again or what to say. And again, I really want to acknowledge the cultural context. We all come from different perspectives in terms of expectations, in terms of religious beliefs, norms, cultural norms, and really appreciating that in the same way that all of these domains may be disrupted, we also need to be able to have a roadmap for what to do to address those issues when they come up. So In terms of the good news, I would just say when I think about sexuality and sexual health, we know that when things are on track, when people feel positive, and when people feel that sexuality is a satisfying domain in their life, there are lots of benefits. It's people are literally happier. There's a sense of relief around stress and self-image, but we also know physically, right? It is good for everything from heart health to pain reduction and immune function. So I think there are lots of reasons from a quality of life perspective why it's important to be able to address this. Last disclosure or disclaimer, I would say before we really get started, is that I appreciate there's a very wide range of normal. Although I would say sexuality is a kind of a normal part of the human experience across the lifespan, that doesn't mean that it looks the same for everybody. There's lots of different sort of ways of function. And most importantly, what I would say to all of you is that if you feel like something is bothering you, if you feel like something is distressing in some way, it deserves attention. And that's really the bottom line. So if there's really anything that feels disturbing or troublesome or anxiety provoking, you certainly deserve to get some help with that. And let's talk about what that might look like. So these are the common problems I want to talk about today. I want to touch on what we call the genitourinary symptoms related to menopause, whether that's loss of lubrication, pain, arousal difficulties, really all of the kinds of symptoms related to what it means to either be in menopause or have an intensified experience around menopause. I'm going to talk about decreased desire. That's probably one of the most common and distressing changes, sort of loss of sexual satisfaction, loss of sexual activity. I want to touch on body image distress and that lack of sense of feeling whole in your body, because we know that's a common issue. I appreciate that relationships can be stressed and that there are role changes, dating challenges, et cetera. And really just acknowledging that all of those things can be themselves not just distressing, but can really add to some emotional burden. So those are really the main topics that I want to touch on. And I think we're just going to get started. So as I was saying with Sarah, there'll be time for Q&A on the other side of this talk, and happy to take questions at that point. But if there's anything to be clarified, we can also pause. So first and foremost, I always start with talking about vaginal health, or what we call genitourinary symptoms, mainly because this is something every woman should really be aware of, whether you are currently sexually active or not. I think it's really important to just know what you need to know in terms of keeping your body healthy, including your genital tissue, including your vagina. We know that when anybody goes through treatment that either puts them into menopause or intensifies the experience of menopause, which is often the case after an ovarian cancer diagnosis, we're looking at a profound loss of estrogen. When we have that experience, that loss of estrogen, there are changes to the vagina, there are changes to the vulva, the external genitalia, and we know there are urinary changes, right? So after ovarian cancer, it is common, often because of surgery, that there may be change in vaginal length. We know there's loss of lubrication and natural elasticity, that tissue becomes less stretchy. The vulva can change. We know that we have less collagen. We lose about half of our testosterone when our ovaries are no longer working. And there can also be changes in urinary function. People may notice they have more frequency, more urgency, or even UTIs because of that loss of estrogen. So this is something which, although is common, again, is not often commonly talked about in terms of what everyone needs to do on the other side of that. When I think about the basics around restoring vaginal health, I'm thinking about moisture, I'm thinking about stretch and blood flow. This is something that, again, I think everyone needs to know, whether you are partnered, single, sexually active or not. And I want to really go over the basics. You can see that again, that little pictogram in the top right corner about the vagina, the sort of inside, and the vulva, the outside. We know that it's really important for women to restore moisture to that tissue. There are different ways to do that. Bottom line is, first off, vaginal moisturizers are products that are formulated specifically for the vagina. I know we talk often about moisturizers people put on their face before they go to bed at night, or their hands in the wintertime. Vaginal moisturizers are over-the-counter, non-prescription, but it's really important that women are aware of that, because most women need to moisturize regularly, probably 2 to 4 times a week. Important to be able to use that moisturizer internally and externally. And there are different types of moisturizers that are out there. Probably the most effective non-hormonal over-the-counter moisturizers are those based on hyaluronic acid. The hyaluronic-based moisturizers you may be familiar with, lots of hyaluronic-based skin products. But again, effective and do all kinds of good things like balance the pH and really sort of hold moisture in that tissue. So I want everyone to be familiar because this is different than what was called a lubricant, which is that sort of stays on the surface to reduce friction during sexual activity. Also, on the other side of that question about what is a moisturizer, just to clarify, we have our non-hormonal over-the-counter. There is an option to use a hormonal-based moisturizer, typically vaginal estrogen. There's also a vaginal DHEA formulation. Again, these are by prescription. They are not hormone replacement. This is local just to that vaginal tissue, come in different forms. You can use a ring or a tablet, a cream. And most importantly, I think this is a question that you need to bring to your oncology team and make that decision in the context with your oncologist. But just to say, if anyone is dealing with any kind of dryness, pain, discomfort with or without sexual activity, really important to be aware of how to get moisture back to that tissue. I'm also a really important fan of letting women know about pelvic floor health. I think this is something that, again, is not talked about nearly as much as it needs to be, especially in the context of sexual recovery. Basically, we all have what is called the pelvic floor. This is essentially a sling of muscles that really goes from front to back. And they're really sort of the core of our base in terms of they help stabilize our internal organs. They sort of help stabilize our back. And they also are very involved in all of the openings and closing down there, right? In terms of urination, in terms of front and back. So you can imagine pelvic floor health is important when it comes to sexual recovery and sexual activity. If those pelvic floor muscles are too tight, over engaged, and not relaxed, it is very common that women have discomfort with sexual activity. We know that on the other side of menopause, it is very common that those pelvic floor muscles lose some of their flexibility. We are often not really aware of our pelvic floor. If anyone's had a baby, you often know that you hear about the pelvic floor after giving birth because people talk about doing Kegel exercises, that feeling of squeezing to engage those pelvic floor muscles. But we also know that on the other side of menopause and cancer treatment, often the issue is not about trying to tighten the pelvic floor muscles, but it's really about learning how to relax the pelvic floor. And this is really important, especially if anybody's having any pain or discomfort with sexual activity. So again, important to know that there are specific aids to be able to help relax those pelvic floor muscles. We also work very closely with what is called pelvic floor physical therapy. There are physical therapists that specifically can work with women hands-on to show you how to do some exercises to relax that pelvic floor. The reason I start with all of this is because I really want to underscore the importance of pelvic floor health in the context of pain or discomfort. It is not uncommon on the other side of cancer treatment that women talk about discomfort with sexual activity. That is not just about dryness, but that's really about an involuntary reaction of that pelvic floor to become over-engaged or very tight. So this is just really a pictogram of what is essentially a cycle of pain. So you can imagine that if you are either anticipating that sex might hurt or that you've had a sexual experience that's been painful, those muscles automatically start to brace. And we all know what that feels like, where you sort of imagine that something's going to hurt and those pelvic floor muscles brace in sort of ways to sort of self-guard or self-protect. And that tightness can make sex so uncomfortable that penetration can actually be impossible. And the fact is, once you sort of get into that cycle, that pain cycle where the body is bracing automatically, obviously it does not make anything very appealing. And really the consequence of that is that people want to avoid the whole situation, which is totally understandable. And the more that we avoid, the more that we're often in a situation where when we try, it's going to be more painful. So really important to just be aware pelvic floor rehabilitation in general and about what we can do to keep the pelvic floor healthy. So again, we're talking about learning how to relax those muscles. We are also thinking about what we could do to help get that tissue more stretchy and more open. you see in that small picture on the right-hand corner of what are called vaginal dilators. These are a set of cylinders that women can use in a very systematic, methodical way to help stretch that tissue. We talk a lot about vibrators and what we can do to get some blood flow and nerves firing. And again, pelvic floor physical therapy. So again, this is not meant to be super comprehensive, but just to give you an idea of the fact that there are a number of rehab options and strategies that we have to really sort of help women manage these changes in the pelvic floor. Again, I'm going to put a plug in for vibration therapy. Hopefully, if you've ever tried, you would know that getting clitoral stimulation might be sort of pleasurable, but we also know that they're therapeutic, right? When we use a vibrator in terms of clitoral stimulation, it gets blood flow to that tissue. It helps the muscles relax. It actually can help relax the vaginal canal and really sort of decrease pain. So again, being able to sort of put these pieces together in terms of sort of next steps for recovery. So that is the, I would say, quick overview about vaginal health and the menopause piece around genitourinary symptoms. But I also want to switch gears to thinking about the pieces that are not mechanical, right? The pieces that are not only physical, but they're also emotional, cognitive, and around body image and whatnot. So let's switch gears. And talk a little bit about desire to start with. I think that sexual desire or low desire is, again, probably the most common problem on the other side of cancer. And the main issue that we often hear is that women say, listen, I'm not in the mood. I don't ever feel in the mood. It's never automatic the way that it used to be. So unlike a light switch, right, where sort of on or off, it is not automatic. And I really want to acknowledge that. We know for most women, on the other side of menopause, or I would say midlife and beyond, the experience of sexual desire really changes. We know that it often does not feel spontaneous the way it might have either earlier in your life or at a different time in a relationship. But what typically happens in terms of the shift, we know that desire is an experience that we have to cultivate. It really has to emerge out of an experience that feels sensual or that feels exciting or that feels emotionally connected. So the idea here is that I don't expect sexual desire to often be automatic or spontaneous. But what I know is that if we sort of reframe our understanding of desire as an experience which is responsive, right, which we can cultivate, it is a very different perspective. So let me give you an example of that. Actually, I have a picture of a toaster. A patient of mine in clinic not that long ago said, I know what you're talking about. It's like when you put toast in a toaster. And I said, I don't really understand what you mean. And she said, well, it has to warm up before it pops. And I thought, oh, that's a good metaphor. So let me talk a little bit about responsive desire. Two, again, metaphors I'm going to use. I'm thinking about one, when you go out to dinner and you feel full and you've had dinner and you feel like you're not hungry, and the wait person asks, if you'd like dessert, and you say, no, I'm fine, no thanks. And then all of a sudden somebody walks by with a molten chocolate lava cake and you smell it, and all of a sudden your mouth starts to water and you're thinking, oh my gosh, that smells really good. Well, actually, maybe I could have a bite of that, right? It's actually a kind of an experience that's very sensual, kind of wakes up your senses. And then you think, oh, actually, maybe I am a little bit hungry. The other metaphor that I like a lot and I often think about is about exercise, which is to say that often we are not spontaneously in the mood to exercise, but that for most of us, once we start to move, we feel better, right? You actually have to start to do something, take a walk, go for a swim, and then you notice that you feel better, which is often what motivates you to keep going. So really the root here point is that desire becomes an experience that we don't expect to be spontaneous, that we do need to cultivate. And I would actually suggest that we can start to kind of get rid of that notion of spontaneity and really think about anticipation, right? Really think about what we can do to look forward to something that we create, that we cultivate, that we build. And I really appreciate that, especially on the other side of gynecologic cancer, where there are so many complicated associations with sexuality, that really might mean developing some new experiences, a new script, expanding our repertoire, really trying to get outside of our usual habits, because it might be that there are some things that are different and that we need to expand and to change. But I really want to underscore that point of desire now becoming a responsive experience where we have to cultivate versus expect it to just be automatic. Going to switch gears to talk for a second about body image and what it means to feel whole in our body. I am not a huge fan of the notion of body image just from the point of view of how I look. I'm thinking of it really from the point of how I feel and what that means to feel whole, especially after we go through so much invasive treatment in a very private and personal part of our body. And I would really want to suggest that, first of all, this experience of feeling whole, this experience of body image is not driven by a body part. I don't really think of our experience as being about defined by a body part, but it's really about being defined by an experience of us as a whole person. So how do we do that? Well, I think first and foremost, we have to cultivate a sense of compassion for ourselves. I think that we are often much more compassionate for other people than we are for ourselves. And that means that, without judgment, really starting to explore how we feel strong, how we feel whole, what we can do to feel connected to our body without feeling panicky, without feeling scared. I think we have to cultivate a sense of kindness and compassion, because I know that that is not an easy process. And I think it can be helpful to really focus on what our body can do, right? Having a sense of compassion for ourselves, for what we've been through, for the sense of strength that we've cultivated to get to this point. And this is where I think sometimes a little piece of counseling or some peer counseling can be helpful, to really reimagine a sense of ourself in terms of this new chapter. But I really want to underscore the point here that I don't really see the value of body image being focusing on a part or a piece, but really sort of appreciating what it is to have compassion for our whole self, and recognizing also that when it comes to dating, for example, or being with another partner, they see you for a whole person, right? And in the same way that, at a certain point in life and midlife and beyond, hopefully we're not seeing other people only as a compilation of parts, but as a whole. I think that's a very important perspective to bring to ourselves as well. I want to switch gears now to talk a little bit about the more psychological pieces of this. I am a big believer in really helping people raise awareness of the connection between thinking and feeling. It is incredible how much, when we go through cancer, we have often a range of automatic thoughts that we tell ourselves, like on a loop, like a tape loop. I have this picture of an old cassette. I don't know if anyone else can remember what a cassette looks like, but research assistant of mine recently said it might be better to have it, the notion of being on loop. But the idea here is that for all of us, we often have a series of thoughts about ourselves and often about sexuality, right? I will never be able to be sexual again. I'm never going to be able to have pleasure again. Nobody's ever going to date me. Nobody wants to be with somebody who feels damaged. There are a raft of these kind of automatic thoughts I hear in clinic every day, every week, which again, impact how we feel. And we are often not even aware of how automatic these sort of thought loops, these sort of automatic feelings or automatic thoughts and feelings are sort of put into play. So, when it comes to these kind of automatic thoughts and feelings, especially in the context of sexuality, it's really important that we learn how to talk back to those thoughts, right? The way that we would with a friend. So often I would just say that in the same way that we might hear a friend say something like that, and we immediately might challenge that person to say, wait a minute, hold on, don't be so sure, right? There's probably another way to look at that, or I'm not sure that's true, right? Sounds like you're making all kinds of assumptions. We don't do that often for ourselves, right? We often don't do that with our own automatic thoughts around sexuality and intimacy. Really important to sort of first and foremost identify what those are, to become aware of what the tape loop is, and then to be able to think about some of those strategies like talking back. Also want to just comment that in contrast to some of this sort of active talking back kind of strategies, sometimes it's also helpful just to know that thoughts come and go, right? So, again, this is not about a contrast, but this is sort of another sort of perspective. We talk about mindfulness-based awareness. There's an enormous focus now on mindfulness-based cognitive therapy across the board. We know that, the concept here in terms of mindfulness is that, when we think about present moment awareness, we think about acceptance and non-judgment, that there also is a way for us to sort of be in the moment without assuming that we have to do anything, right? Including argue with ourselves, but that we can also recognize sometimes thoughts come and go, and that's okay. So bigger picture, again, really sort of trying to build a full whole person perspective that when it comes to sexual recovery, when it comes to next steps, it's important to figure out what is impacted. Is it that I'm mad at myself and I'm always talking to myself in a certain way that it's not helpful? Or is it that I'm aware that I'm avoiding things with my partner and I'm not sure what to do? Really just trying to invite folks to sort of think about where things may have been disrupted and where you might need to go to sort of get some help. So I do want to talk for a minute about this notion of avoidance, because this is something that, again, is really common, not just after gynecologic cancer, but after cancer in general, is that we know that when people have some kind of distress related to sexual health, whether it's worry about pain or discomfort, or whether it's about not being sure how to, talk with a partner, or feeling comfortable being naked in front of a partner, whatever it is, it brings up understandable anxiety, right? Raises feelings. People feel uncomfortable. And there's automatically often a negative self-talk piece, right? Nobody's going to want to date me, or somebody's not going to be attracted to me, or perhaps I'm never going to be attracted again to my partner. I don't know. But something that leads me to a place where I want to avoid the whole thing, right? Where it is my immediate unconscious perspective is to do anything I can to distract or not go to bed at the same time, to avoid the whole thing. And the thing about avoidance is that it's powerful, right? Sorry. When I avoid something that's uncomfortable or anxiety provoking, in the short term, I immediately feel better. It's a relief. Phew, I don't have to deal with that. The tricky part about avoidance is that the more you avoid something and you have that short-term relief, it actually reinforces the feeling that you have to avoid that thing that was upsetting. This is a very powerful dynamic around sexual health, because the more we avoid, the more we feel better in the moment. But again, we really reinforce the feeling that there's a lot to worry about and that this is too difficult to deal with. So I want to invite you to think about a different pattern, right? When we think about what that would mean to move beyond avoidance. If, for example, we know that the goal or the value is that I want to enhance intimacy, I want to get back to some kind of better function, first and foremost, I probably have to tolerate or accept that this is going to be a little bit uncomfortable, right? This might not be easy to do right away. I might not be able to talk to my partner immediately without being a little nervous, or I might not be able to think about this for myself without feeling a little uncomfortable. But most importantly, the very next piece is that we can reframe some of that negative self-talk, right? We can talk to ourselves in a way, again, with compassion. We can reframe some of those negative automatic thoughts that I mentioned before and just say, hold on, I'm not so sure. There might be a different way to think about that. And more importantly, instead of moving to avoidance, we think about action, right? We think about having a plan. We think about having a next step kind of action plan for what I can do, who I can talk to, who I can meet with, what kind of pelvic floor physical therapist or doctor or friend or whatever it is that you're needing, but that I have a plan for what to do. And that when I actually start to do something, I notice something changes, right? I have an experience where I know something is different. And this ultimately allows me to create some new habits. But this is a very different model than when we start out with avoidance, right? Leads us to a kind of a different place. I will say, in terms of the interpersonal impact, again, whether relationships are longstanding and very solid, or whether it's a new relationship, I know that it is hard to talk about sexuality in the context of cancer survivorship. Often survivors just simply don't feel like they're the same person they used to be. People often feel stressed out or guilty. They're not meeting their partner's needs. I know that that is not a sexy place to be. I also know that when sexual activity feels like a chore or an obligation, it certainly doesn't feel like something that you're looking forward to. And that is obviously an issue when we're talking about cultivating desire, right? If you are at cross purposes with wanting to cultivate desire, but feeling guilty or feeling stressed, that's not going to be helpful. And I know that's not a turn on, right? So when I think about recovery in the context of relationships and interpersonal pieces, I think it's important to clarify what are the shared goals? What are the individual goals, right? What can we do to enhance or increase communication? And again, with intention, how do we create a new chapter, right? How do we create a plan for how to, in a very kind of safe and systematic way, create a kind of a new way of connection? So I would say from a relationship recovery point of view, my focus is really on pleasure. It's really on what feels sensual and what feels pleasurable. I think it's important to be able to go slow without being pressured, without being goal oriented. And I think it's really important to have a more expansive perspective on what sexuality is, right? So that might mean not just doing what you used to do, but really trying to sort of think about how to slow things down and expand what sensuality looks like. Maybe taking a lot more time to actually start dating somebody that you've been with for a long time, right? Where you start slow and you're really kind of expanding the repertoire. And I will just say sometimes a little piece of counseling can be helpful, even in terms of improving communication or thinking about how to help you have some new ways of connecting. So I guess my summary slide is really that I think first and foremost, we do have to accept that there are certain losses that are real, that are profound, that change is genuine. I am not in any way going to say that things can be the same, because very few things we know are the same on the other side of cancer or cancer therapy or living with cancer. But it is okay to embrace a new course, right? It's still okay to say there is still another way to do this, and that if we can take off the pressure and give yourself time and space to come up with a plan, right? Where you sort of feel like you have specific next steps of what to do. It is a game changer. And the good news is that there are really more supports and resources now than there really ever have been. When I started doing work in this area now more than 20 years ago, there was not a lot, right? And that's one of the things that I think has changed. So again, I think it's important to talk with your team if you have very specific questions, whether it's about vaginal estrogen or whether it's about how to find a PT, for example. Anything that is bothering or distressing about sexuality, I really believe deserves attention. I think it's a critical quality of life issue that is under addressed for so many people. And please don't be afraid to keep asking questions if you don't get an answer the first time you ask, because it may not be that you're the person you're talking to is knowledgeable, and that's okay, but that means that you don't stop, right? That there's still more to go. Again, a lot of resources out there right now in terms of a number of organizations, whether that is through an organization like this wonderful group that we're with today, or whether that's through American Cancer Society, whether that's through the NCI, there are a lot of resources available. And I'm really happy to take questions. So I hope that 4:35. I think we have plenty of time. I hope I didn't speak too quickly. But I don't know if there are questions, Sarah, but more than happy to stop. So I'm going to stop sharing and go from there. Thank you.
Great. So just a couple to start off. So first one, which some of our other guests actually also had shared some input is, are there any specific moisturizing products that you recommend?
There are a number. I mean, as folks know me, I don't represent or sell any products in particular, but I would say that there are a number of very high quality products. There's a company called Good Clean Love that makes a very nice product. I would say that Hylogen, Hylogyne, any of the hyaluronic based vaginal moisturizers are probably the most effective non-hormonal moisturizers available. So yes, that's where I would start. I don't know if I said this before. Maybe I did not. I'm not very good at multitasking, so I'm not going to try to read the chat simultaneously. But I would say that I do think it's important in terms of I don't think I actually mentioned about vaginal lubricants, in contrast to moisturizers. Lubricants, again, are not meant to sort of hold water in the tissue, but really are meant to be just sort of on the surface to reduce friction with sexual activity. I would say either a water-based or a silicone-based lubricant is better. There are gynecologists who say silicone is Good Clean Love, the name of the moisturizer product company. But I would stay away from products that have glycerin for people who may be prone to yeast infection. Glycerin can sort of act like a sugar and promote that. So I would just say, anything that has a lot of perfumes, additive dyes, you don't need that. Coconut oil, I just saw somebody said that. So coconut oil is great. Women have been putting coconut oil all over their body for probably tens of thousands of years. We are not big fans of internal use for coconut oil. I would say that external use of coconut oil, you can leave a jar of coconut oil in the bathroom and apply that around the opening of the vagina, what's called the introitus, after you take a shower or bath. It really helps moisturize that external tissue. I don't really think it's best formulated for internal use. So I would say external use 100%. But I would tend to use one of the vaginal moisturizers for internal use. Do these things work if you're over 70? They work if you have a vagina at any age. The only thing I would say, and I'm going to be frank about this, is that if you have had significant, let's say, dryness or menopausal symptoms for a long time, the over-the-counter non-hormonal moisturizers may be adequate, or may not be sufficient, put it that way. So that might be where there is a conversation with your doctor about whether you could use vaginal estrogen or vaginal DHEA. I think that I'm very aware that there are cancers that are estrogen receptor positive. I'm also aware that vaginal estrogen is not systemically absorbed. So I would say that's a conversation to have with your oncology team. But the moisturizers are effective, and the good quality moisturizers tend to work pretty well.
Another question is, can you please address testosterone and whether it has a role?
So, we know that I think there's a greater understanding of the fact that testosterone is part of women's makeup right from the beginning. When ovarian function ceases, as I said, we lose about half of our testosterone. Testosterone is also some of that is produced in the adrenal gland. This is something that has not been studied adequately, I would say, in the sense that, for example, we don't have any FDA approved testosterone products for women in this country. There are people who are working very hard to work with FDA to change that. There are other countries, for example, in the UK and Australia, where there are testosterone approved products for women. So in this country, for women who use testosterone, it is off-label or off-treatment, or off-label use with a different formulation. And you have to typically work with a urologist who's comfortable prescribing that. The data is complicated around testosterone for women. Some women find that it does actually help, right, in terms of enhancing desire, libido, et cetera. But again, I think that has to be something that is used cautiously, responsibly. I think that there are hormones are a big business in this country right now. And I would just say that it's really important to, especially if you're a cancer survivor, to work with somebody who is knowledgeable about the evidence, who is not just kind of in a big business, but who is, I would say, clinically and academically aware of what the data is, and then to be able to sort of use that responsibly. I do worry that there are people that are getting lots of hormones right now in a super physiologic dose, that it is not healthy. So important to find a provider that is competent and knowledgeable.
Thank you. Next one is, do you recommend oral probiotics that are focused on vaginal health?
That's another great question. So that is something that is being marketed. We actually do not have a great evidence base about how that is directly related to sexual function. So I would say that I can't honestly say that I know the answer to that, because I think that is something that, although is being marketed, it's unclear to me how that works exactly. So I'm not sure I could endorse that. It may be helpful, but I would say that's something that we still need to learn more about.
Next one is, what are your thoughts on using hydrocortisone ointment for irritation? My regular gynecologist has recommended this.
I guess it depends on what the irritation is. I mean, hydrocortisone is used for lots of, kind of topical use irritation. I'm not, uh, again, I would say it really depends in the sense that, if you're having irritation largely because, let's say, the tissue is depleted from estrogen and you don't have enough moisture, it might be better um, to be using something that's going to directly address the moisture. I would say that vaginal tissue, genital tissues generally can become pretty fragile. I would wonder about long-term use of something like that. So I would say short-term use if your doctor says it makes sense, and if it takes away the issue, I get it. But if you have a problem with that's long-term and not going away, this might be where I would seek a second opinion, either from a urologist or a urogynecologist who might be able to weigh in on that.
Next one is it okay to use vaginal estrogen and a lubricant simultaneously?
Sure, absolutely. So lots of people use vaginal estrogen and additional, topical lubricant. That's no issue at all. Lots of people actually, I apologize, I have a cough, obviously. There are lots of people who will mix and match. So, for example, there are women who might be using a small amount of vaginal estrogen twice a week, let's say with a suppository, but it helps. Let's say it manages the urinary symptoms, but they notice that they're still having a little bit of dryness and may use an over-the-counter vaginal moisturizer 2 other days a week, so that every other day they're using something. So it is not uncommon to mix and match. And I think the main thing is that I'm not a fan of trying multiple products at one time, because if you are having any irritation or any kind of reaction, you don't know what's what. So I would just say I would introduce multiple products simultaneously. I would start with something, make sure that it agrees with you, you're not having any kind of allergic reaction, but you can certainly add in a moisturizer and a lubricant or a second hand of moisturizer, something like that.
Yeah. Next one is there a resource that you would recommend for finding good providers such as yourself locally?
Oh,
And then she
thanks.
said, I've tried
Sure.
North American Menopause Society and they don't seem to understand the oncology aspects. Is there another organization focused on
Right. So
sexual
I
health?
would say so there is a wonderful small organization, full disclosure, I past president and part of it, called the Scientific Network on Female Sexual Health and Cancer. I know that's a really long name. We should probably rename it. But again, if you Google Scientific Network and Sexual Health, or Scientific Network and Cancer, you will come to the website. There is, I believe, find a provider function on that website. The other, I do think that even with the North American Menopause Society, I will say that there are a number of providers who do have specialization with working with cancer survivors or cancer patients. So, I'm sorry that it might not have been ideal for when you looked at it previously, but um, I do personally also have a number of colleagues who are involved. The other main resource that I highly recommend would be the ISHWISH, which is again a shorter acronym, but it stands for the International um, Society for Women's Sexual Health. So let me actually just Google that myself. So it's ISSWSH. ISWISH. That actually stands for the International Society for the Study of Women's Sexual Health, as I said. That is all about women's sexual health, not just menopause. And there are a number of providers, ISWISH providers, again, who have a kind of particular expertise or specialization in women's sexual health and cancer. They have an excellent find a provider, a much more detailed find a provider directory as well.
Thank you. Are you aware of any research regarding risks of estrogen suppositories after estrogen positive ovarian cancer?
Correct. So this is something that has been looked at. Again, this is not the research that I do, but there are a number of studies that sort of have been done, sort of retrospective studies looking at the literature. I'm not going to weigh in on this as an expert. I'm not a gynecologic oncologist. I will say that there are absolutely experts who agree that looking at the data that it is safe to use vaginal estrogen after ovarian cancer. There are also individual oncologists who would say for particular patients it is not their first choice. So I would say that I would not say that across the board it is either safe or unsafe. I think that there are probably differences in terms of risk factors for each patient. There have been papers that have been published looking at this, and there are papers published looking at this that have not found that vaginal estrogen increases risk for recurrence. So I would say this is where it is worth talking to your individual provider to get more detail on why they would or would not recommend this for you. The other piece I will also just say, and that's sorry, just to add to that, sometimes a provider might say, well, listen, I'm not sure that I would want you on this forever, but short-term use would be fine, right? And sometimes using vaginal estrogen, for example, for a short amount of time, let's say 3 to 6 months, in order to get that tissue healthier, is just enough for you to be able to then switch over to a non-hormonal moisturizing regimen that allows you to maintain the health that you've sort of regained with the short-term estrogen. So there are different ways to sort of to look at that.
Great tip. Thank you. I think we have covered all of the questions that have been in the chat. Let's see. Is any final questions before we wrap up today?
Yeah, I mean, I guess I would just sort of say, Sarah, again, my point really to everyone is that there are absolutely resources out there. I'm really thrilled, like just even seeing in the last 10 years, how many people that I know are reaching out to me saying, we want to start a sexual health program. We want to have something, at my cancer center or at my hospital. And I really appreciate, I think somebody also just put the ASECT. So ASECT is sort of the major sort of sex therapy accrediting organization. Again, not everybody may be as sort of educated around the cancer piece, but again, has a very comprehensive find a provider directory and both national and international. And I just think it's important for people not to give up if they don't get the help they need when they ask the first person they ask, or, an individual, in reality, both doctors and nurses get very little training in this, right? So sometimes it's important to really just to sort of give yourself the permission to keep asking and to advocate and to use the resources that you can find online.
Thank you. And we did actually get one more question, which was for the recommendations you shared today, is this any different for women who have or have not had hysterectomy?
I don't think so. I mean, I think that, for women who've had hysterectomy, sometimes because of surgery, there may be some vaginal shortening, right? I think that sometimes women are dealing with some slightly different issues. So, for example, some of the kind of strategies that we talk about in terms of managing um, uh, uh, sexual activity, let's say with a vaginal canal that is shorter. So, for example, there's a wonderful uh, um, sexual aid, for example, called the O-Nut. I know that's a strange OH-NUT. It serves as a little silicone buffer. So if you imagine putting a little buffer at the base of a penis, the penis becomes shorter, and then it's a kind of a mechanical workaround when you're thinking about a vaginal canal that may be shortened. So again, lots of specific kinds of resources that have been developed for specific kinds of problems. But, all of the issues that we talked about in terms of menopause, in terms of desire, I think they're the same. But I would say for anybody who's had a hysterectomy and is noticing that they're having pain with sexual intercourse, and that has to do specifically or also includes something to do with the shape of the vaginal canal being different, this is where some pelvic PT can be really helpful, or thinking about something like using a buffer, right? If you're having sexual activity with a male partner, that's something that's like a little workaround, but is really useful and it really helps, really helps.
Wonderful. Thank you so much. Any more questions before we finish up today?
Thank you for all the good questions. I hope I was able to address them, but it was really, I'm glad that people had them. So thank you for asking.
Yeah, and thank you for this incredibly insightful presentation. Thank you for, directly addressing the elephant in the room. It's refreshing to, kind of hear these topics just discussed openly and plainly and directly. So,
Sarah,
appreciate
can
the
I?
efforts to normalize the conversation. Mhm.
No, thanks. I actually, if I know we have one more minute, if it's okay, let
Yeah,
me just
no,
sort of end by
absolutely.
saying one more
Go
thing.
right ahead.
You know, we know that physicians, medical providers generally often do not bring up this topic, right? And I just want to say that, in the years that I've done this work, which is now a long time, one of the things that bugs me is that it often gives patients, gives survivors the misperception that there's nothing that can be done because the thought is that if a provider doesn't bring it up, this is just the kind of the price I have to pay, right,
Right.
for
Yep.
being alive. And I
Makes
and I want to
sense.
say, if there's one kind of false narrative, that's what I want to get rid of, right? So that even though your provider may not ask, may not bring this topic up on the front end, it doesn't mean that one, it's not important, and two, that there's nothing you can do about it, right? That's not true. And so that's, if there, I would just say that's the part that feels to me like I really just want to sing that from the rafters, that,
Yeah.
even though you may not be hearing from that from your team, it doesn't mean that this is the price you have to pay to being alive, that there really are lots of strategies that we can do to just make things better, make things different. It might not be the same, but we can make things better. So yeah, so thanks for letting me share with all of you today.
Yeah. Super important takeaway. And thanks so much again for this incredibly insightful presentation.
My pleasure. Thank you.